Our next speaker is Dr. Mahesh Ramchandani, and he's a cardiac surgeon here at Methodist Hospital. And he is perfected, and he's an expert, world expert in the minimally invasive coronary bypass surgery, among other things. And he's going to talk to you today about coronary artery bypass for stable coronary artery disease.
Hi, good morning to all of you. I won't be touching on specific techniques of coronary bypass surgery, except to mention them in passing, talking more broadly about the rationale for coronary artery bypass surgery in the setting of stable coronary artery disease, picking up on some of the points that Dr. Shah made earlier. So we'll spend a little bit of time, a couple of slides on the history of coronary bypass surgery, talk to you about the indications and the evidence that underpins coronary bypass surgery in stable coronary artery disease, touch on outcomes and morbidity, a little bit about evolving techniques in coronary bypass surgery, talk a lot about Cabbage versus PCI, which is an important discussion and one which is still unresolved. I wouldn't say largely unresolved, but it's still unresolved, and there's a lot of work to do there, and a little bit about future trends. I would encourage you, not just on this topic, but on other topics that you will hear about today, valve disease, AFib, whatever it may be, to go to the latest society guidelines on the subject, because they not only summarize very well the current state of evidence, but they are truly, the societies put a lot of work into it, and they convene expert panels that spend a long time looking at all the evidence and come up with levels of recommendation for different types of intervention in the setting of, in this case, coronary artery disease, but it could be any of the conditions. So it's a very easy way for you to get a good literature review put together, and an expert consensus opinion based on that these societies give. In the case of myocardial revascularization, the latest guidelines that exist are in fact the 2014 European Society guidelines. The ACC and the AHA, the most recent ones are in 2012, and they're very similar, but the more recent ones will capture obviously more current trial data. So in 2014, Cabbage turned 50. The first one was done in 1962 by Dr. Sabiston, and the patient didn't survive. The first survivor was right here at this institution. Ed Garrett was the surgeon. Dr. DeBakey and Dr. Howell were there in the room as well. And all those three surgeons have passed on since. In 1964, in Russia, Kolosov did the first Lima to the LAD. 7 cases that were reported. And what is actually very remarkable, and most people don't know this, is that at least 2 of those cases were done using an anastomotic device. The Russians were extremely advanced in the development of anastomotic devices, and the vascular anastomotic devices didn't really go much beyond then, but they became very sophisticated in the development of bowel anastomotic devices. And I remember when I was training in England in the 80s, it was not uncommon to, even at that point, to be doing bowel anastomoses, particularly for low anterior resections, using what we called then the Russian gun, because it was, developed over there. This is a slide of the first case that was done. Dr. Howell very kindly gave it to me, and I made an electronic version of it. And you must remember that Mason Soanes came up with selective coronary angiography in the early 60s, and so the quality of pictures wasn't very good. But with the eye of faith, you can see that there's a left main stenosis over here. I've looked hard at it to try to figure it out, but I take their word for it. But this is a post-op film here showing a patent vein graft going there, and this patient did very well. So cabbage really evolved starting in the 50s because of the development of cardiopulmonary bypass by James Gibbon. This was a grant that was given to him by the chairman of IBM, who was a friend of his. Angiography in 1962 at the Cleveland Clinic by Mason Sones, cardioplegia in the early 1970s, two really separate tracks, the Brett Schneider in Germany, and that solution in a modified form is being used today. It's called custodial. And Mark Brainbridge at St. Thomas's Hospital in London developed St. Thomas's solution, which is probably still the most widely used cardioplegia solution. Off-pump CABG started in the 1990s, and minimally invasive techniques for CABG really began to be developed in the 2000s and are still not widely practiced. So the evidence for CABG really rests in three large trials in the 70s and the 80s, and it's important, I think, that you be not just aware of them, but read them, because it's the main basis that allowed this therapy to take off. It compared CABG to medical therapy. Stents weren't invented then, of course. 10%, less than 10% of patients received a Lima graft. Okay, that's very important to know. And of course, medical therapy is not what was not then what it is today. Statins weren't invented. You know, there wasn't aspirin wasn't routinely used. Beta blockers weren't being used routinely. There wasn't the awareness that these things made a difference. So the three trials really came out in 1983. The coronary artery surgery study showed that in patients with triple vessel disease and depressed ejection fraction, CABG was superior to medical therapy. The VA study, which came out in the New England Journal in 1984, again showed that patients with triple vessel disease and poor left ventricular function did better with coronary bypass surgery. And the European coronary surgery study, which came out initially in the Lancet in 1980, and then an updated follow-up in the New England Journal in 1988, confirmed these findings and showed also that patients with two vessel disease who had a proximal LAD lesion did better with coronary bypass surgery. In the early 90s, Yusuf in Los Angeles, Professor Yusuf really did a meta-analysis of all the available trials and published it in the Lancet, and basically showed that it was an aggregate of 2,650 patients followed over 10 years, and showed that CABG improved survival and symptoms, and the benefits were most in patients with triple vessel disease, left main stenosis, impaired left ventricle, and severe symptoms and positive exercise ECG. Now, when you look at these trials, you have to understand that the benefits of CABG were underestimated for severe disease, because back then CABG was still a relatively nascent procedure, and the patients that were being enrolled in these trials were patients who were deemed to be low-risk patients. The results were done on an intention to treat basis, and more than 40% of the medical patients crossed over to CABG. And only 10% of them received an IMA. So even with these criteria in the groups that I've mentioned to you, CABG was shown to be superior. But in spite of this, there was no survival benefit for CABG in single or double vessel disease without a proximal LAD lesion and normal LV function. So the recommendations for future trials were that they should include a higher proportion of patients for whom CABG is known to be superior for medical therapy. It's not advancing, Terry. Okay. Now the major morbidity of CABG obviously is stroke, which is multifactorial. It can be related to cardiopulmonary bypass, the aorta, cerebrovascular disease, because these patients have vascular disease in not just the heart, but almost always in many other locations. Myocardial infarction, something that you're trying to prevent, is a potential complication of coronary bypass surgery. Pulmonary complications, kidney complications, And nowadays you can calculate the specific risks with the STS calculator. All you have to do is Google STS risk calculator, and the top hit that comes up will be this online method for you to calculate the risk of any particular patient that's sitting in front of you. It takes about three minutes, perhaps 5 minutes tops to do it. And it's based on the STS database of about 1.6 or 1.7 million patients now, which started in the early 2000s. About 95% of institutions in this country that do that do cardiac surgery participate in the STS database. And the overall mortality is about 2% for all comers. And the lowest risk group nowadays, the mortality is, it says 0.5%. The expectation is close to zero, practically, for the lowest risk patients. Cabbage itself has evolved, and Dr. Rule will talk to you about conduits, the IMAs, saphenous vein graft, radial, gastroepiploic artery, on pump, off pump, minimally invasive, sternal sparing, with or without cardiopulmonary bypass, endoscopic vein harvest, and a hybrid philosophy of combining surgery and stents. So you see, the whole field has gotten very muddied. The initial trials looked very cleanly at coronary bypass surgery and medical therapy. But as with everything in medicine, the moment you study something, a new iteration comes along, a new philosophy, a new way of looking at it comes along. But that doesn't mean that there is no value in what was studied before. The trick is to find out what value there is and apply it to your current treatments. Of course, in 1979, all of you will know this, and if you don't, you should. This was a landmark paper that was published by Andreas Grunzig, a Swiss cardiologist, on the first report of successful PTCA. This revolutionized the cardiology field. He was an avid pilot, had his own plane. He moved to Emory University shortly after this, and tragically died shortly after that, a couple of years after he moved to Emory in a plane crash. He was flying his plane, and sadly had an accident. But he triggered off this whole field of percutaneous coronary intervention, and there was this approach that was, well, okay, now we have another way of revascularizing that doesn't involve opening up the chest. And we know that revascularization, albeit by opening up the chest, is superior to medical therapy. And so they claimed equivalence to Cabbage, and therefore they claimed parallel benefit over medical therapy, using the evidence that had been gleaned from the trials that I mentioned earlier. And for many years, this was not studied at all. I won't go through, there's been obviously many, many trials that were done between then and this one, which was the Courage trial. That was the first good trial that looked at PCI versus medical therapy, analogous to the trials that had looked at Cabbage versus medical therapy. This was the first time this head-to-head comparison, or the best one certainly, the Courage trial. And there were almost 2,500 patients randomized to PCI with optimal medical therapy versus optimal medical therapy alone. Now, patients in this trial obviously, were being monitored very closely, and compliance with the medical therapy was very high because of that. There was no difference in death or myocardial infarction in up to 7-year follow-up. But PCI was better at relieving angina. It was better at relieving symptoms. So it's important to know that if patients come to you with disease that can be treated with PCI and they have symptoms, PCI is better at improving symptoms than just medical therapy. But it was no better at preventing MI or death. Can you advance it? There we go. So now the next trial that I'm going to spend a little bit of time on, because I think this is an important trial, was the Syntax trial. And this was a randomized controlled trial of drug-eluting stents versus Cabbage. 85 centers in Europe and the US, all comers to mimic the real world. There was no cherry picking involved. There is no trial prior to this or since that has really had the enrollment rates that this trial had. 4,337 patients were screened and astonishing 71% were enrolled. This is really amazing because if you know anything about trial enrollment, you will know that if you achieve 10–15% enrollment out of patients that are screened, you're doing very well. So this really was an all-comers trial. 1,800 or 58% of these were randomized equally, and the remainder were enrolled in a registry because most of them were deemed too complex for PCI. So this decision was taken by a heart team. This was the first time that a heart team concept was really put in place. And it was done as a matter of trial design. The folks who designed the trial required that to be the case. And so the cardiologists that were on the heart team would look at these patients that were coming in and say, well, we agree they've got triple vessel disease, but for technical reasons, we don't feel that it's safe to offer PCI. So they were placed in the Cabbage arm, they were placed in a registry arm and offered Cabbage. All of them were screened by a heart team, and the composite endpoint of death, stroke, MI, and repeat revascularization was used. Now, one of the most important contributions, and some say the most important contribution of the Syntax trial, was the development of the Syntax score to assess the complexity of coronary artery disease. Now, this means that no longer would you look at a coronary angiogram and say, that looks like, you know, complex disease, that looks like pretty straightforward disease, and that's something in the middle. There was a way that you could now actually score it. And our fellows over here, our cardiology fellows, do so routinely. It takes about 10 minutes to score it. It's a little tedious, but once you get good at it, it's something that you can do and you can come up with a number. And this is one snapshot of a Syntax score diagram. And what they do is they look at each vessel and each branch of each vessel, and they assign a score to it. So you can see that you have to go through an angiogram and go through the different views. There's a methodology and a way of doing it. You look at each specific view and you score the vessels, and then you come up with a score at the end of that. And so there's three vessel disease and there's three vessel disease. So here you've got a patient, you know, with a Syntax score of 21. Less than 22 is considered to be a low score. You see that they've got very focal disease. There's a 70 to 90% LED lesion. There's a focal 70 to 90% circumflex lesion. And there's a couple of focal lesions over here. And if you look at the vessels, outside of those lesions, the vessels look pretty good. And then you've got a patient over here who's got a left main disease, who's got an occluded circ, who's got LAD 99%, but more lumpy, bumpy lesions, diffuse disease in the RCA, very high Syntax score. So in all comers, I'll talk a little bit about the whole Taxus issue versus the Xience and the more modern stents. With respect to Dr. Shah, and I've had this discussion with him on many occasions, I don't think it's as relevant to this discussion as some would have you believe, and I'll explain why. But when you looked at all comers, there was a very significant difference in MACE between the group that had Cabbage in terms of survival out to 5 years versus PCI. And it was clear that Cabbage was the superior modality. But if you looked at patients with a low Syntax score, there was no difference. There was no significant difference. And this is going out to 5 years. So this was really very revealing. It was very, very revealing. And it was a very important information for our patients. And there is a criticism that you can make that this was a subgroup analysis, and therefore it wasn't powered really to reach the conclusion that many have reached from it. But nevertheless, the trial was conducted well, the data were collected, you know, well, and you know, this is something that that certainly has made us pause and strongly consider PCI for patients with low syntax scores. You looked at the intermediate score patients, and the difference began to separate. This is between 23 and 32. And in the high score patients, high syntax score patients, the difference was the greatest. So the final 5-year results of the syntax trial demonstrate that surgery remains the gold standard for patients with complex multi-vessel disease. In patients with less complex disease, PCI is an acceptable alternative, and the treatment decisions for an individual patient should continue to be made in consultation with the patient and the heart team. We'll talk a little bit about the heart team at the end and how we kind of implement it over here at our institution. The FREEDOM trial looked at Cabbage versus PCI in diabetics. Okay, so we've talked about Courage, which looked at Cabbage, PCI versus medical therapy. We've talked about Syntax, which looked at Cabbage versus PCI in all comers. And then FREEDOM looked at Cabbage versus PCI in diabetics specifically. By this time, the syntax score methodology had been created, and they used it in this trial. The mean syntax score was 26, which was sort of in the intermediate range, and they showed that for all-cause death, MI, or revascularization, Cabbage was superior to PCI. The numbers are there: death 10.9 versus 6.8. MI was much less in Cabbage. Less revascularization, and the curves began diverging at 2 years. Stroke, however, was higher in the Cabbage group at 5.2% versus 2.4%. There are registry data out there as well, and this is just one of them. The Northern New England registry is another one. This is the New York State registry. Duke has maintained a registry for decades now, about 2 decades, which shows a similar sort of curve to this one. These data that were published in 2005, and they've continued to follow them, and they show the same thing, indicate that certainly in registry data, 3-vessel disease with proximal LAD, Cabbage shows superior survival to PCI alone. So we talked about stents and different types of stents, but why is Cabbage better than PCI? PCI treats an isolated lesion in the vessel. Okay? The complexity of the lesion affects the outcome. So it's not just that all lesions aren't the same. If you sit down with an interventionalist, with an interventional cardiologist, and look at an angiogram and hear how they look at a lesion, they will be looking at specific lesion characteristics and thinking in their mind as to whether this is a complex lesion or a less complex lesion, and it affects the outcome. In Cabbage, that's irrelevant, right? Because you're not doing anything to the lesion, you're bypassing the lesion. You are bypassing the proximal 2/3 of the vessel where the current lesion, and importantly, future threatening lesions occur. Which is why in complex disease, where you have a medium or a high syntax score, you've got the main culprit lesion, but you've got lumpy, bumpy disease down the line. That is not being addressed by PCI, but Cabbage goes around all of that. So the complexity of the disease is irrelevant, and this advantage of Cabbage will persist even if stent restenosis is 0. In other words, if you created the perfect stent where you placed it in a lesion and the restenosis was 0, it still wouldn't address everything else that all the other disease that the patient has. And that's why I think that even though there is a significant difference, not just I, but I think most people feel this way, even though there's a significant difference between the Taxus stent and the Zion stent of today, you're looking at a 3, 4, 5% difference in restenosis, which is not going to impact this outcome. This is inflammatory, but I won't put it up. So the lemur is protected from we'll go back, why not? This is the cover of the Lancet in January of 2006. The Lancet, as you know, is a medical journal, meaning it's a non-surgical journal. And in view of the survival benefit shown for coronary artery bypass, the real controversy is why patients with symptoms and anatomy known to benefit from the procedure are still submitted to PCI. So, the lemma, it's protected from atherosclerosis. Why? We don't know. It's the unquestioned standard for surgery in coronary artery disease, and it's an important metric in the STS rating of institutions, where 10 to 15% of an institution's star rating is based on what percentage of your patients receive the lemma. It's used in greater than 97% of coronary artery bypass. But so is it Cabbage or is it the lemma that's conferring the benefit that we talk about? We don't know. It's impossible to fully dissect the independent benefits of the IMA versus a saphenous vein graft in the same patient. There's no head-to-head trial of SVG only bypass versus stents will ever happen because it wouldn't be ethical. Okay? Any comparison of SVG to stents therefore would be quasi-scientific, and nonetheless most surgeons and cardiologists agree that the majority of Cabbage benefits rests with the IMA. This benefit of the IMA was first shown by Fred Loop at the Cleveland Clinic in this classic paper in 1986. And was confirmed later by a study at the Cleveland Clinic where they looked at 4,500 patients who had had previous coronary bypass surgery and who came back with symptoms, and most of them had a patent lemma. The overwhelming majority had a patent lemma. They looked at those with a patent lemma and they found that repeat intervention for new coronary artery disease may help the symptoms. In other words, if you treated them with PCI or redo surgery or medical therapy alone, you may help their symptoms, but there was no survival benefit for any of these interventions, one over the other, if the patient had a patent lemma. In other words, your lemma was going to keep you alive and everything else was going to give you symptoms. We also know, and this is just one study, the vein graft patency in the PREVENT study where patients, this was a study that was performed looking at a decoy that would supposedly prevent endothelial proliferation. And as part of the study design in vein grafts, and as part of the study design, all the patients were to get an angiogram at 1 year, which is something that we don't routinely do. And they showed that there was no difference in the patients that were treated with the decoy versus those that weren't. But remarkably, they showed that about a quarter of the patients that they did angiograms on at 1 year, a quarter of all patients had vein graft failure. There are other trials that have looked at it, and vein graft failure, I think most people will agree varies between 12 to 15% to up to 25% at 1 year. Stents are constantly evolving, and target lesion revascularization or stent restenosis is about 2.5% in this trial, and the best stents today achieve about a 1 to 2% restenosis rate. The FAME2 trial, I don't know that Dr. Shah addressed it, but this was FFR-guided PCI, showed that for patients with FFR or fractional flow, did he talk about FFR? Yeah. Patients with fractional flow reserve of less than 0.8 were randomized, symptomatic patients were randomized to medical therapy versus FFR-guided PCI. This was planned for 1,600 patients, but was stopped by the Data Safety Monitoring Board after 888 patients because there was clear superiority for PCI over medical therapy for FFR-guided PCI. In other words, you don't just look at it and say, I think that's bad and I'm going to treat it. You get a number that actually tells you what the functional significance of that lesion is and treat it based on that. So if you look at the guidelines for revascularization from the European Society of Cardiology, indications for revascularization in patients with stable angina or silent ischemia. There's a class 1 recommendation. Now this is revascularization. It doesn't distinguish here between PCI versus Cabbage, but there's a class 1 recommendation for left main disease, any proximal LAD greater than 50, 2 vessel or 3 vessel disease, greater than 10% ischemia on a nuclear test, and patients with a single remaining patent coronary artery. And for this is for prognosis. And for symptoms, any coronary stenosis greater than 50%. So if someone's having angina and they've got a lesion, it's logical to treat it somehow. In terms of Cabbage versus PCI, you'll see that there's a class 1 recommendation for Cabbage in all of these that are listed over here. And for PCI, there's a class 1 recommendation for 1 or 2 vessel disease without proximal LAD, for which 2B for Cabbage, 1 vessel disease with proximal LAD, 2 vessel and left main disease, and 3 vessel disease with a syntax score of less than 22 has received in these guidelines 3 years ago a class 1 recommendation for PCI. So for the first time, the guidelines actually offer it a class 1 recommendation. Class 1 incidentally is recommended, 2A is probably beneficial, 2B is not sure if it's beneficial, 3 is might do harm. So Lima for life, stents for symptoms, and best medical therapy. We don't know, but coronary artery disease is like cancer, okay? It is inconceivable in this day and age that any major institution would treat a patient with breast cancer with just one doctor making the decisions, or lung cancer, or esophageal cancer, or colon cancer. You always have at least 2 or 3 people involved. It's a multidisciplinary approach. And coronary artery disease is like cancer. It's about disease management. It's about the patients and not procedures. It is such a, the manifestations are so protean that it's really impossible for one person with his or her lens to be able to bring to bear everything that is known about the treatment of coronary disease to the decision making required for any individual patient. Okay? That is not to say that you can't, in many, many cases, perhaps the majority of cases, make a good decision because of the fact that we know enough now that you can look at somebody with triple vessel disease and left main stenosis and say, well, you know, this is, and he's a reasonable surgical candidate. But there are so many patients that are in this gray zone that really it's important to have an approach where you sit down with colleagues and try to figure out whether PCI, Cabbage, best medical therapy, or a combination of those is the best treatment for the patients. Thank you.